And when you're transferring the FCR to the EDC, you're going to put it for all the fingers, isn't it?
Yes, sir. I will check the if there is lag in the EDM. If EDM is lag behind, then I will transfer the FCR to EDC plus EDM also.
Okay. Then what is the third for the thumb extension? What will you do?
Sure. I will reroute the EPL from the third compartment. I will divide it from the musculotendinous junction, and I will attach with palmaris longus.
You will attach it with palmaris longus. Okay. What is the you're going to do this procedure under what anesthesia?
Uh, as a- I want to do it under general anesthesia.
Okay. Okay. Why general anesthesia?
Because if during harvesting of pronotal teres, if I miss the periosteal cuff, I will not hesitate to take the tensor facilitator graft to uh, attach with the ECRB and pronotal teres.
Okay. Okay. Where will you make the incision?
Uh, Sir, may I show the incision picture?
You're showing pictures. Okay. We're going to the procedure now. Please go ahead. Now, before
Okay.
we go into the procedure, you have made a plan for a tendon transfer. Okay.
Yes, sir.
So you want to carry out the plan immediately, or you want to wait for some time and then carry out the plan?
As patient was in cock-up splinting for 2 years, I will
Yes.
carry out the plan immediately.
Okay. So you have checked all the muscles. They are of good strength. Okay. Now go
Yes,
into
sir.
the surgical. How you will do the surgery?
So I will take three incisions. I will take one volar legious incision from the mid forearm to the wrist to explore the pronotal teres, FCR, palmaris longus, and through the same incision, I will identify the ECRB. With the dorsal incision, this is Lister tubercle. I will identify the EDC and EPL and EDM.
No, no, I'm sorry.
And
1 minute. 1 minute. The first volar incision, you said you'll identify the ECRB with that?
yes, sir. I will retract the skin flap and I will. I can find it, sir.
Oh, you can find it with this incision. Are you sure you can find the ECRB with the incision that you have made over there?
Uh, yes, sir. If I retract the brachioradialis and the skin flap, then it could be possible. Otherwise, I will
Okay.
approach to the dorsal incision.
Okay. So with that incision, you're going to get the ECRB. Then what else you're going to get?
Uh, with the volar incision, I will get pronotal teres, flexor
Yes.
carpi radialis, and palmaris longus.
Very good. Okay. Yes. Then the
Then
dorsal incision.
dorsal incision in the middle of the posterior forearm, and I will check the extensor carpi, extensor digitorum communis and extensor pollicis longus, as well as extensor digitorum minimi, if
Okay. Yes.
required.
Yes.
And third
Then.
incision over the anatomical snap box for rerouting of EPL tendon.
Okay. Ah.
Okay.
Right.
So my plan is to take a strip of periosteum around 2 to 3 centimeters periosteum along with the pronotal teres, and I will free
One
up the
minute.
muscle
1 minute. Why are you taking a strip of periosteum along with the pronator teres?
because it attaches like a fan shape. So that muscle, if we take the muscle bulk, it suturing will be difficult. So as a
Suture will be
tendon,
difficult.
uh,
Yes.
so to gain the tendinous length, I will take the strip of periosteum.
Okay. Where is the pronator teres inserted in the radius?
Uh, so it's insert in the distal one third of the radius.
Distal one third? Distal one third?
Uh, s- I think, sir. I just confused, sir.
Yes.
Distal one
See,
third,
the
which
thing
pronator
is,
is inserted.
when you are presenting a case, you should not show pictures from the book about how the tendon transfer is done. You can show
Okay.
pictures about the clinical examination. That's all. There's no point in your showing the complete picture of the tendon transfer. No, there's no how. I mean, how do we discuss? Okay.
Okay, sir.
So don't
Okay, sir.
worry. So
Okay,
now
sir.
you have talked about the middle third. The insertion is into the middle third. Okay.
Yes, sir.
Now, what tendon, what muscle should you retract to get the insertion of the pronator teres?
So I have to retract the brachioradialis.
Very good. You have to retract the brachioradial. Right. Now you have taken a insertion of the pronator teres along with the periosteum.
Yes, sir.
Okay. Then what do you do?
Then I will free it up high up to gain the length, and
Yes. Good.
I will come over the brachioradialis and ECRL, and I will
You want
transfer.
to go over the brachioradialis. Why do you
Yeah,
want to go over the brachioradialis?
um, to minimize any addition or any uh, tension over the if I transfer in between the brachioradialis and ECRL. To avoid that, for a proper gliding, I want to come over the
Yes.
brachioradialis and ECRL.
What will happen if you take the pronator teres under the brachioradialis?
The
What?
excursion will be less
Why?
because it brachioradialis will impinge the promoter muscle.
Actually, when you're taking it over the brachioradials, you are following a greater distance. If you go under the brachioradials, you're reaching it at a shorter distance. It is actually better. But what is
Okay.
the problem there? You have taken away the periosteum from the radius, isn't it?
Yes, sir.
So that means this transfer tendon will get stuck to that raw area on the bone.
Okay, sir.
Okay, so you have taken it over the brachioradials. Yes. Then how will you suture it to the?
So I will suture it with pulvar tuft weaving. I will
Okay.
I will incise the with number 11 blade. I will make a nick on the extensor carpi radialis brevis, and I will suture with horizontal mattress, and I will continue this another suture up 1 centimeter from the initial suturing. I will make another
Okay, you will do a pulvar tap. How will
pulvar
you
tuft.
adjust the tension before suturing it?
So at the time of suturing to promoter teres to ECRB, I will make the wrist at 45-degree extension and promoter teres at full extension, full strength.
Full stretch, yes. Pronator teres in full stretch and
Wrist at 45-degree extension.
very good, very good. And suture it. Okay,
Yes,
then
sir.
you want to do this first or you want to do the FCR transfer to the EDC first?
No, sir. I want to do the wrist first, then fingers, then last thumb.
Okay, right. Now, how do you do the FCR transfer?
Uh, to for FCR transfer with the dorsal incision, I will open up the compartment 4 and I will check the EDC with a Alice forceps. I will pull it and I will check
With what forceps?
with a Alice or Kelly clamp. I will check with that.
Alice forceps. You will hold the tendon and pull it.
No, actually we go beneath the tendon and I will pull the tendons.
Okay, with the Alice forceps.
Big one.
Okay.
Alice or
Okay.
artery forceps. Hemostat.
Artery forceps.
We
Okay, you're cutting the tendon. Are you going to cut the EDC
no before
tendon?
yes sir. Before cutting the tendon, I will check the whether all the fingers are acting or not.
Why you want to cut the EDC tendons before doing the transfer?
Yes sir.
Why do you want to cut them?
Uh, and I want to cut because and I want to come over the extensor retinaculum to prevent the gliding in the extensor retinaculum.
Okay, if it is very distal, then you have to cut the tendons. Otherwise, it's not needed to cut the tendons, right?
Okay, sir.
Okay, yes. So now you've taken the flexor carpi radialis. Then you have not yet taken the flexor. You have just identified the EDC tendons.
With the volar incision, I will check the flexor carpi radialis and palmaris longus. Palmaris longus will be the almost a superficial midline structure,
No, you have
and
not finished the FCR still. Flexor
uh,
carpedials, you're not finished.
so the dorsal most radial structure will be the flexor carpi radialis.
Yes.
Uh, so I will detach it from its insertion,
Where
and
is it inserted?
it's inserted in the second and third metacarpal.
Base. Okay.
So from that I will detach it, and
Yes.
I will free it to gain the length, and I
Yes.
will with the in the between this dorsal incision and volar incision in between the skin flaps, I will pull the FCR and suture
Yes.
the with
You
the
said,
EDC.
yes. You said one point about you will free it. What is that? What
Yes,
does that mean?
to gain the length.
What will you do?
Other, uh, I will remove attach the I will or remove all the facial attachments
Very
of
good.
the
Till where? Till where you will go proximally?
uh, till I get the maximum length.
No, no. Can you go till the insertion of the flexor carpi radialis?
No, sir. It's origin. I will not go to up to the origin
Yes. Why?
because it is not required, and if I go, I might have injured other structures.
What other structures?
Uh, uh, so median can be
The nerve supply. The nerve supply to the
supply.
FCR will be cut.
Yes, sir.
Yes. So you have dissected out and you have brought it to the, you have tunneled it to the dorsal aspect.
Dorsal aspect.
Yes. And you are suturing it to, how will you suture it to the, there are 4 tendons there.
Yes, sir. I will suture all the 4 tendons together, and I'll make a nick, and through that nick, through and through, I'll pass a artery forceps, and I'll pull the tendon, and it will be looks like a side end to side, but it is a end to end anastomosis only, and I
Yes.
will
Now, this FCR tendon that you're bringing there, is it going to come at a right angle or a different angle?
comes at almost at a right angle.
Is it? You said that one of the principles is it must be in a straight line. Now you're
Yes.
saying you want it to go at a right angle.
No, no, sir. Pull will be in the straight line, but
How will the
suturing.
pull be in a straight line? How will the pull be in a straight line if the tendon is inserted at a right angle? Do you understand?
Yes, sir. I understand. I don't know, sir.
Normally, if you want the pull to be in a straight line, you should attach it end to end.
Yes, sir.
But here you cannot do it end to end because there are 4 tendons there and you've got only 1 tendon here.
Yes, sir.
So what is the next best position? You cannot attach it at a right angle.
Yes,
You
sir.
cannot attach it at 0 degrees. So
Yes,
what
sir.
do you do? So you have to attach it at a
45 degree,
45,
5 degree
45
angle.
degree angle. Okay, you got that?
Yes, sir.
And what is the tension adjustment now?
Wrist will be neutral, MCP will be in neutral, and FCR will be in full stretch.
Okay, so wrist will be neutral. You have already done the tendon transfer for the wrist,
Yes, sir.
isn't it? So you have kept the wrist in neutral position for this and MCP joint in
Neutral.
neutral position. Okay, right. So you have done this. Now how are you going to do the thumb EPL?
For thumb with with dorsal incision, I will free it up I will cut the EPL from the muscular tendinous junction,
Good.
and I will take it out from the compartment 3 and
Yes.
reroute it over the anatomical snap box from to the
Yes.
polar side, and with polar incision I will open up I will find the palmaris longus, and I will check up to the proximal part whether I am taking the palmaris longus or not,
Okay.
and then and then I will divide the palmaris longus at the wrist joint, and I will suture it with pulvar tube with the thumb, with the EPL, with thumb in IPJ in extension and MCPJ in extension, and radial abduction, and
Okay.
palmaris longus in full strength.
Okay. Now what POP are you going to apply?
Sir, I
And
will
how long?
Sir, I will apply a POP above elbow POP uh,
Yes.
with the wrist flexed at
No,
uh,
no. Above elbow POP first.
POP with elbow flexed at 90 degree
Yes.
with wrist at 45 degree.
One more joint between the elbow and the wrist. There's one more
Sorry,
joint.
sorry. Forearm pronation at 30 degree.
Yes.
Uh,
Yes.
Wrist at 45 degree extension.
Yes.
MCP is mild flex 15 degree.
Yes.
IPs are left free, and for thumb, MCPJ and IPJ are full extension with radial abduction.
Okay. So, okay. How long are you going to leave this POP on?
So I will keep the POP for 4 weeks.
For 4 weeks. After 4 weeks, what will you do? When will you
After,
change the dressing?
I will change the first dressing on third day.
You will change the dressing?
I will change the first. Yes, sir.
Do you change the dressings after a tendon transfer?
Yes, sir. I will check the. I want to see the scar and wound. So I will.
You want to see the scar, not scar. You want to see
Oh,
the
this is
wound,
the
suture line.
wound, suture line.
You want
So
to
I
see the
will.
suture line. Okay. Why are you worried about the suture line? What will happen if you remove the POP at the end of 3 weeks? How will you do the dressings? Will you remove the POP or not?
Yes, sir. I will remove the POP.
Will you remove
At
the
4
POP after doing a tendon transfer, after taking so much care to adjust the tension? And you are saying you want to remove the POP?
POP at after four
Yes.
after 4 weeks. I will change the I POP.
So you don't want to do a dressing on the third day. You have changed your mind now. No, you don't want to do a dressing now. You said you wanted to do a dressing, isn't it?
And again, yes, sir. If I do the dressing and again I will put the POP on the same position.
Yeah. So you're not worried about causing a change in the tension that you have done.
Yes, sir.
You're not worried.
I'm not
It
sure.
is usually not necessary. It's not necessary to change the POP at all. It's advised not to. Because when you take it off, you've already taken, you said, no, this I will keep it in maximum tension and that in 45 degrees. You have taken so much tension, you have taken so much efforts to keep it in correct position. And now
Yes.
you should not harm that position, isn't it?
Okay, sir.
Okay, so it is advised not to remove the POP. You are not worried about it. It's not a trauma where you're going to have a bleeding there or infected wound over there, isn't it?
Yes, sir.
So it is not necessary. So what is best? The best answer would be, I am confident about my suturing. I will not remove the POP for 4 weeks. Right?
Okay, sir. Okay,
Right.
sir.
Then after 4
Then
weeks,
I
what do?
then I will start gradual exercising of the shoulder and IPJ
Yes.
first,
Yes.
and then I will start single joint movement.
Yes. What is that?
Single joint exercise. Yeah, for the when we will do the wrist exercise, we will do the wrist extension only, not the fingers and IPJ. For the thumb IPJ at the same time, we'll do
Okay.
the only wrist, and when we'll do the
Okay.
finger extensor, we'll do the finger extensor exercises only.
Yes. So one by one, you will get the joints back into movement. That's what you mean, isn't it?
Yes, sir.
Okay. So now you have finished everything. Tendon transfer is over. Will you ask the patient to wear the splint now? The patient had a splint in the beginning, no dorsal, the dynamic cock-up splint.
Yes, sir. Yes, sir.
Do you want the
So
patient to wear the splint?
Up to 3 months, I will advise for the exercise and night time
Yes.
splinting.
Yes. Good.
But
Just
after 3 months, full activity can be done by the patient himself.
very good. Very good. So there is no need for splint after 3 months, but in the beginning you have to give it as a protection. Okay.
Yes, sir.
Now this patient came to you at the end of 2 years. Now we have got another 5 minutes in which we are going to finish this.
Yes, sir.
Patient came to you at the end of 2 years. Supposing patient had come to you at the end of 2 months. Patient has had a plate and screw fixation. POP removed at 1 month. Patient has got a wrist drop.
Yes, sir.
How will you proceed?
Sir, I will check with the EMG and nerve conduction study and high resolution ultrasound to check whether nerve have been intact or not.
Okay.
But I will not I will check the nerve regeneration with the nerve conduction study.
Okay.
But and I am expecting, if the nerve is regenerating, I am expecting that it will regenerate in 4 months. First muscle to be innervated is brachioradialis.
Yeah. Now the thing is, patient has come to you at 2 months. Will you offer immediately surgery?
No, sir, I will manage conservatively. I will follow up
Will
if
you
the
will manage conservatively? Okay. You want to manage
yes, sir.
conservatively. Please remember,
Yes, sir.
you want to manage conservatively. You said, isn't it?
Yes, sir.
Please remember, patient has told you at the time of injury, patient was not able to extend the wrist and fingers. And secondly, the plate and screw fixation has been done and patient still has a wrist drop. Do you think,
Yes, sir.
why did the patient have, in the beginning, when the patient had an injury, also patient had not able to extend the fingers? So would you not
Because there,
suspect an injury to the nerve?
yes, sir. I am suspecting the injury to the nerve, but I don't know whether it have been at that time it have been repaired or not. If it is repaired, I found it is repaired, OT note, I will manage conservatively. Otherwise, I will proceed for the nerve repair.
Okay. Now, whenever a question is asked like this, patient has come to you at the end of 2 months with a plate and screw fixation, your first answer should be, I will try to contact the orthopedic surgeon if possible to find out what was the finding on theater. It's only 2 months since the plating,
Yes,
isn't
sir.
it?
Okay, sir.
So you should try to find out. You should say, I will contact the orthopedic surgeon if possible to find out what was the finding on the table and whether they have done anything. So that
Okay.
will give you a guide about whether to continue conservative management or to go and explore inside. Okay.
Okay, sir.
Right. If your investigation is not very conclusive, it will not be conclusive.
Yes,
Supposing you
sir.
have decided to wait, how long can you wait?
Sir, I will usually it takes 4 months to get the brachioradialis function, 4 to 6
Yes.
months. So
Yes.
I will wait. So I will wait up to 6 months.
You will wait up to 6 months. If the 6 months, if at 6 months it's not able to come back, you're not seeing
Then
anything. What?
then I will go for the nerve repair with nerve grafting.
Nerve repair, nerve grafting. Okay. So you want to do a nerve grafting then.
Yes,
If you
sir.
do a nerve grafting, then this you're doing at the end of 6 months. If you're doing a nerve grafting, is there any other procedure you will do along with the nerve grafting?
Yes, sir. I will do the internal splinting with pronator
Very
teres
good.
to CRB, end-to-side and anastomosis, end-to-side coaptation.
End-to-side suturing. Okay. So you want to do only pronator teres to ECRB, isn't it?
Yes,
So
sir.
that is
Yes.
internal. Very good.
Yes, sir.
Okay. So your presentation was good, but you need to sort of I was asking you the practical questions about how you'll do the surgery. Okay. That you
Okay.
need to brush up. You are quite good on that tendon, adjusting the tension in the tendon transfers and all that. But I think in the anatomy, you were a little confused about the insertion of the pronator teres and all that.
Yes,
Okay.
sir. Yes, sir.
So just brush up on that. Otherwise, it's okay. Now we'll go into the different questions. If there are any questions that have been asked, are there
Yes,
any
sir.
questions, Sandeep?
Yes, sir. There are a few questions, sir, that has come up.
Yes, I'll see the questions now.
Yeah.
Can we go
I mean,
through
they're quite.
I'll just go through this quickly. Can we go through
Yes, sir.
the muscle belly of brachioradialis? Indranil, where is Indranil? He's run
Yes, sir.
away.
Yes, sir. Yes, sir. I am here.
Yeah, can you answer that question? Can we go through the muscle belly of brachioradialis?
No, sir. We should not go, as you
No,
explained.
that's all over. Next, what should be the position of the wrist and MCP during palmaris longus to EPL transfer?
The wrist will be at the neutral, and MCP will be also in neutral.
In neutral position while you're adjusting the tension. Okay. The next is, yeah, somebody has already answered that. If we adjust tension in a neutral position of the wrist in case of FCR to EDC transfer, so there will be chances of tension over the suture site of pronator teres to ECRB transfer in neutral position of wrist. Please explain. Actually, this the thing is, when you're adjusting the tension, the wrist is already kept in extension, isn't it? The wrist is kept in extension because you have transferred the pronator teres to the ECRB already. Now you're going to adjust. It's a very complicated because there are two movements occurring across the wrist joint. The first is the wrist extension is going to occur. Second, the transfer that you're doing for the finger extension is also going to cross the wrist joint. So in that situation, first, the primary wrist extensor, that is the ECRB that has been transferred with the pronator teres, first is adjusted. After adjusting that, if you adjust the finger along with, supposing for the ECRB transfer, you have kept the wrist in 45 degrees extension. Agreed? Now, supposing you want to do the finger extensor also with the same 45 degrees of wrist extension, it will become too tight. You cannot flex the fingers completely because, as you know, the muscle that you're transferring is the flexor carpi radialis, which has got only 30 millimeters of movement. So the wrist extends, the fingers cannot move beyond 30 millimeters. So there will be a deficit in flexion. So that is why we keep the wrist in neutral position and then suture the extensor to the fingers. Then the next question is, any role of nerve transfer if patients presents early in case of wrist drop, which you were discussing in the end. Here, wrist drop. Now, is there a role? Where is Indranil?
Yes, sir. Yes, sir.
Yes. What nerve transfer can you do?
Sir, we can do the median nerve supplying the FDS and the FCR and the PL to the and the pronator teres to the nerve supplying radial nerve supplying to the ECRB and the EDC and the EPL.
Very good, very good. Okay, so you can do it when you're taking the nerve to the palmaris longus in FCR. You can put it directly to the posterior interosseous nerve, so you get a much better innervation of the muscles. Right. The next question, Rakesh Kumar Sinha, is when to use dynamic, when to use static splints. A very simple answer: when there is a bony problem, use static splints. When there is a nerve problem, use dynamic splints. Very simple. So when you have a nerve problem, when you have a median nerve palsy, use a dynamic opponent splint. When you have a radial nerve palsy, use a dynamic cock-up splint. When you use static splint, when there is a fracture or when you are immobilization after surgery, in that situation, you don't want any movement, you can use static splints. The next from Vamsidharan Muthukumar, in combined nerve injuries, what are the other options? Especially if median nerve is also injured. I think we don't have time to discuss that. That will be a very interesting topic. But I think we will stop with this if there are no more questions. And I will hand over to the organizers to go ahead, to go forward. It was a good presentation, Indranil. Congrats.
Thank you, sir. Thank you, sir. Thank you, sir.
Yeah, thank you very much, Indranil. It was very nice.